Hello, it's Anthony Chadwick from the Webinar Vet, welcoming you to another episode of VETchat, this time around our mini-series around what is a massive problem, but also so much progress has been made, and that's around veterinary oncology. Very fortunate today. It's always great to hear from the other side of the pond. We've got Rachel Venable with us, who is the proprietor at Pet Cancer Care Consulting. We're going to be talking about that in a bit, is also board certified in oncology. Rachel, it's great to have you on the podcast.
Yeah, thank you so much. I'm so excited to be here.
Great. And perhaps, Rachel, just for people who aren't familiar with you, certainly on this side of the pond, perhaps you can just give us a little bit of an introduction. When did you, first of all, decide to be a vet? It's always an interesting one to know.
I'm one of those, I was actually older. I was in high school. A lot of people you hear ever since they were little kids, they've known. And I grew up on a farm. So I'd always been around animals. I'm from the center part of the US. I'm from Missouri. And
Yes.
so I knew I wanted to work with animals, but originally I actually thought zoo animals. So when I was in high school, I did a job shadow at a zoo. And that's where I realized the zookeepers, so basically the people cleaning up after the animals, had, higher education, had difficult college degrees. And I was like, well, I want to do more than clean up after animals.
Yeah.
And so then I really started thinking about the vet because the zoo vet got to do a lot. And so then I went back to my hometown area and started hanging out with vets and just fell in love with it then.
Fantastic. And then obviously you went to Missouri for your first degree, for the veterinary degree, and then have moved around doing internships and residencies. So perhaps just tell us where you've been doing those.
Yeah, so I went to vet school at the University of Missouri, like you said. That's where I'm from. A lot of times in the States, you kind of go to the state school where you live. And then my internship was at the University of Georgia. And then residency was at Colorado State. So it was fun to kind of move around the country because Georgia is very different than Colorado, which is different than Missouri.
Yeah.
And also, you get to see how people practice medicine differently and different diseases. The stuff we saw down in Georgia, I did not see in Colorado. Georgia, everything has fleas and ticks and heartworms. I don't know if you guys get some of that stuff out there, but
Yeah.
Georgia was like if you missed 1 month of your heart guard, the dog was positive. They always had heartworm. Versus Colorado, I remember one time we found a tick and it was even one of the faculty and they freaked out because they'd never seen one. They didn't want to touch it. So it's just
Yeah.
very different.
Yeah. I mean, it's such a massive country, isn't it? And I'm sort of with you in that I went to my very local vet school, which is in Liverpool, where I'm from. But then obviously went off to do dermatology. And I remember listening to Michael Dryden, who's Mr. Flea, of course, in Florida, and going to somebody's house, one of the vet's houses, and there was a plaque outside the door, and it said, "This is the house that the fleas built," because of course they sell so much flea treatment. And then I remember, I think, speaking to Rod Roseychuk, who was based at Colorado State University, and he said, "We basically don't see fleas in Colorado because it's so high up." So yeah, it's fascinating. And then obviously Georgia, you're starting to get into the south and more almost subtropical diseases that are becoming more and more important, spreading with climate change and things as well, aren't they?
Yes. Yeah. And then now I'm in Arizona, which we've got valley fever, which when I was in
Yes.
vet school, I remember learning about different fungal disease. Missouri has a lot of fungal disease because it's very humid and the rivers and things. But I remember valley fever or coccidiomycosis, it was always one big test question, like the NAVLE, that's our big certifying test. There would always be
Yes.
one on there. And it was kind of this, you'll never see this in practice, but it's a good test question. And now that I'm in Arizona, everything has valley fever. Like it's wild. A dog has coughing, it's valley fever. They have seizures, it's valley fever. Like it's wild.
And how do we, obviously going a tiny bit off oncology for a second, but how do you treat that? And it's interesting. It's very much with all diseases, cancer can often be on that differential, but treating and diagnosing for cancer is the first thing, isn't it? So presumably as an oncologist, you see a lot of things that you have to first of all make the diagnosis, is it or isn't it? Because people may refer things across to you as oncology, but actually you then discover that it isn't. And I always talk about these reactive lymph nodes compared with neoplastic lymph nodes, it can be quite a difficult diagnosis to see, is that lymphocyte reactive or neoplastic, isn't it?
Yes, and I feel like for a lot of vets, the diagnosis, that's because they're the front line, right? They're the ones that they come into. Normally, it's pretty well honed down, or when it comes to see me, we've already kind of ruled out a lot of things. And so I think for vets, something to keep in mind, especially any lump or bump, really, the needle and syringe is your best friend, right? I mean, if you can aspirate it, just do it. I mean, sure, there's some things that it's just going to come back blood or fat, and maybe that's what it is, right? Maybe it's a lipoma or something. But I think so often, because even valley fever, going back to that, can present as multiple lumps on a dog. But if
Yeah.
you aspirate those, it's all this inflammation. It looks very odd compared to, like, if it was a mast cell tumor, you see those beautiful round cells. And I also
Mm.
always tell people, stain at least one slide in the clinic, because then one, does this look like a lot of inflammation? Did I get a good sample? Like, you don't need to sit there and scroll through and diagnose it for people. Like, that's why you send it to the lab. Have the professional tease through, the slide. But I think for the vet, just make sure you got a good sample, because if you are only seeing blood and fat, well, maybe that's what it is. But also, you can tell the owner, you can say, look, I'm not staining all these, but from what I'm seeing, it just looks like blood and fat. So that may be what
Mm.
it comes back as. Especially if you're worried, like it's something really hard, like you think it could be a sarcoma, or, you don't believe it's a fatty tumor, then you can tell the owner, maybe we should jump to biopsy. Or if you do send in the slides and they come back blood and fat, I find the owners aren't angry because they were already kind of prepped for that.
Yeah.
Right. So I think it's so important to just sample, check it in house, and then communicate with the owner.
I must admit, funnily enough, in Liverpool, we don't see coccidioidomycosis, but I remember there were all these funny fungal diseases in Mullakirk and Scott that, of course, we just don't see in the UK, but often presented as lumps and bumps. And I agree. I think my most profitable tool that I had in the practice was my microscope, and actually doing cytology as a clinician, taking that sample, staining it with DiffQuick. Mast cell tumor is very easy, I think, for most people to do. Um, but it helps you get better because, of course, if you send it away and it comes back as something completely different than what you thought, at least you're learning through that, if you like, failure. But failures are often the best way to learn, aren't they? Where you say, "Oh, I think it's a mast cell tumor," and it ends up being something, different or weird and wonderful. So I must admit, I really enjoyed doing cytologies when I was doing more dermatology, because I think it's a skill that we can learn, and it's very quick, isn't it? We get an idea. Is it a fatty lump? It's probably nothing to be too worried about, but you know, the dog's insured or you're worried about it. Let's get a second opinion from somebody who is doing this all day, every day.
Exactly, exactly. It's so cheap, but you can charge, right? I mean, it's another thing. I
Yes.
think sometimes vets, I don't know about in the UK, but I feel like in the US, we're not always good about charging for some of those things because it seems so second nature. But it's like, no, the owners are okay to pay for that because it's telling them so much. It can tell them, does it look concerning or not? That's why they came to see you.
Yeah, and as I said, I think the microscope was a big profit center for me. Get a good microscope, be able to go to those lower powers, particularly, or higher powers, should I say, for bacteria and fungus and so on. But it's I think I found it very satisfying because it does give you that immediacy of potential diagnosis, doesn't it?
Yes.
To take it completely off topic, there's nothing better than finding a scabies mite. Do you have those in Arizona?
We do, but I'll be honest, that's one of those where I would just start itching, like, I don't even know what to do. If I would be like the faculty member that freaked out that saw the tech. If I saw scabies, I'd be like, "Oh."
I think now
But
with
yeah.
all the good ectoparasiticides we've got, of course, they're becoming rarer and rarer. But no, that's great. So yeah, let's talk a little bit more about diagnosis. Obviously, you are seeing cases sometimes with a presumptive diagnosis, and it may not be cancer. New graduate coming out into Arizona, doesn't know the state that well, sees a dog with loads of lumps and bumps, probably doesn't first of all think about valley fever. But what are tips for vets? all over the world. How do you go about diagnosing? What are the sort of tips and what are the things that can trip you up?
I would say the first thing is to listen to the pet owner. I think often we kind of have our own agenda or we're in a rush, and but they really can tell you a lot. If they don't think their pet's doing well, we do really need to lean into that because they would know, right? They're with them all the time. So I think if they're telling you things like, "Hey, I just noticed this new lump." Don't just brush it off, right? Like pay attention. Or if they're saying, they're really just not eating as well or they're not getting around. So I do think it's important, first of all, to really listen to what they're telling you. And then on exam, especially lumps and bumps, usually we'll say, anything that's been there for more than a month, if it's greater than a centimeter, firm, those are things you at least want to put a needle in. I mean, yes, it could still be fatty, it could still be a cyst or something, but especially if the owner is bringing it to your attention, they want to know what it is. And so it's so
Mhm.
simple just to aspirate it. And even sometimes lumps that feel soft, they don't even feel hard. Mast cell tumors are that great hider, right? They can look like
Yes.
anything. And I've definitely seen these soft, ill defined, you would have thought it was fat, but there's actually a mast cell tumor in there. So,
Mhm.
again, if the owner's like, I feel like this goes up and down in size, that should be a huge red flag in your mind that, oh, this could be a mast cell tumor.
Yeah.
Um, the other thing that I always like that dermatologists do that I find a lot of general vets don't necessarily do this is the punch biopsy, because I get a lot from you guys, cutaneous lymphoma usually is
Mm.
it. And I find most of them when I'm reading through the history, they've had this history where they didn't respond to antibiotics or allergy med, they just had red skin or maybe they had sores, but sometimes it's just this diffuse redness, hair loss. And I feel like dermatologists, you guys just will do like a little punch biopsy and you're done. Like you don't make a big deal about it. It's not like we don't have to put
Yeah.
this dog under anesthesia and schedule him for this whole big procedure. Like we can do this quick and we can get an answer.
Can I share a little pet hate with you
Yeah.
as a vet? When a vet actually has a feel of a lump and says, "No, I don't think that's cancer." I mean, that is like a superpower if somebody can just feel a lump and know if it is cancer or it isn't. I mean, do you have that superpower or do you still think cytology is that important?
I do think cytology is important. I do think there are some lumps. So, like sebaceous adenomas, poodles get those. They have a classic appearance on the outside. So, I do
Yeah.
think there are some lumps where you kind of are like, okay, I know what this is. But for the
Hmm.
most part, I've seen these weird pedunculated masses that turned out to be mast cell tumors, or I've seen
Yeah.
things in the file where it says they thought it was an inclusion cyst that ruptured and it turned out to be a mast cell tumor, actually a really aggressive one. So I've seen that a few times. So while it's tempting, like you say, to just feel it and be like, oh, that's nothing and move on, to me again, you're not really listening to the pet owner if they're bringing it to your attention,
Yeah.
right? If they're worried, then just take the time and again charge, make sure you're covering for your time, but evaluate that mass. It's very quick. And because I've definitely had pet owners come to me where they're like, I had been telling my vet about this lump for
Hmm.
months and they just kept telling me it was nothing, and then all of a sudden, it really grew and now it's a real problem. So I think too often we get busy and we just think like, oh, that's probably nothing and move on with other things. But again, that's that whole listen to the pet owner. If they're worried, we should at least check it out.
I tend to as a person, and as a vet, often think if I went to the doctors with a lump and the doctor had a little feel of it and said, "Oh, well, it doesn't feel like anything. Don't worry about it." As a vet who knows a bit about clinical, I would not be happy with that. So if we sort of think the way that we would think if it was us rather than the dog or cat, it's a much more empathetic way of looking. And as you said, if somebody's, I mean, obviously sometimes lumps and bumps are discovered by the vet at a clinical examination rather than the client feeling it. But if the client has come in just saying, "Oh, it's a lump, it's probably benign," this is cytology is so useful to help. But if in doubt, it's a removal, or as you say, punch biopsies are really useful. I suppose the kind of exception is if you take something a lump away and you haven't taken it away in clean margins, you can make things worse rather than better, can't you? So then that's the kind of exception where we have to be a bit more careful, don't we?
And that's where I think aspirating, like if you've already poked that lump and you know, like, oh, this looks like a fatty tumor, or, I keep saying mast cell tumors because I feel like that's what people see the most. Because if you
Yes.
know it's a mast cell tumor, then when you go in to do surgery, you're going to be prepared that, okay, I can't just shell this out, right? I
Yes.
mean, and so I think that really helps with that surgery that comes back incomplete. And then it's like, oh, what do I do now? I have to tell the owner this, So if you do just a little planning up front, one, the owner's now expecting it. So they know it's a cancerous tumor and they're expecting a bigger incision. Sometimes people freak out about that. The incision
Yeah.
looks so big. So if you explain to them up front, and some of this, it doesn't need to be a long conversation. I mean, you can just say this in a few sentences, but it's enough to prepare them. So mentally, when they see their dog, they're like, oh, yeah, there's that scar they talked about.
Yeah. Exactly. Yeah. How are you feeling about that? We were very busy during the pandemic doing webinars and conferences. And of course, it was at that time that Stelfonta was released. We helped to launch the product for Verbac. Um, Seems a really cool product. And it's always one I like to use as an example of why we really should be protecting our rainforests, because potentially there are so many great medicines in there that we haven't yet discovered. Is Stelfonta a product you like and use in your practice?
Yes, I like Stelfonta. I think it's like most things. I think it's knowing, the appropriate use for it. I'm
Yeah.
not one that's going to tell you, oh, everything gets Stelfonta and just
Mm.
inject every mast cell tumor. I don't think that's appropriate. I think surgery's still best. If
Yeah.
you can cut it and get it off, that's still ideal. But there, we've all seen those mast cell tumors, especially on the limbs. That's usually where
Yes.
it's the hardest, where it's like, gosh, I don't even think we can debulk this, And so you're actually looking at removing, multiple toes or the whole limb sometimes if it's higher up. And so I think it's a really great option when surgery is not a good option, or even sometimes on the head. It makes me a little more nervous on the head, but people have had pretty good success. And I always show owners pictures. I'll pull up the Verbac or the Stelfonta. They actually have separate websites, but I'll pull up and show them pictures because a lot of people, they'll kind of grimace, but they're like, oh, okay, I can handle that. Versus, like my father in law would pass out. Like there's some
Yeah.
people that can't handle blood and wounds. So you just got to
Yeah.
make sure you got the right tumor and the right owner.
Yeah. Well, I always think, I do study veterinary websites as well sometimes. And vets, of course, like to show the vet in scrubs doing a quite sort of aggressive piece of surgery. Whereas I think most people just want to see pictures of fluffy dogs and cats, don't they? Really, they don't want to see the blood and the guts.
Exactly. Yes.
But listen, perhaps if we could talk a little bit about pet cancer care consulting, because of course, and I don't know the stats, and you possibly will know better than me, but there must be so many cases of cancer that never ever go to the referral vet. They're dealt with in house, or they're not dealt with. They're dealt incorrectly with. So I think there is a real place for advice, isn't there, for first opinion practitioners to be able to speak to people like yourself and to get advice. So I'm presuming that pet cancer care consulting is very much peer to peer rather than you speaking to clients directly, or can you explain how the service works and perhaps a little bit of the history?
Yeah, thank you. So, yeah, pet cancer care consulting, which I know it's such a mouthful, but you know what it is, right? Like
Yes,
webinar vet, you know what that is. I'm not a
yeah,
big fan of the nebulous names that you don't know what it is. But
exactly.
so it's a service I started a couple years ago to exactly that, increase access to care because there's so many people with pets and we know cancer is a huge problem. It's estimated about 50% over the age of 10, have cancer or will get cancer. And the other thing, oncologists, there's not that many of us. Depending on where you look, there's something like 450 to maybe 500 registered oncologists in the US and Canada. And that just means registered. That doesn't mean they're still practicing. So
Yeah,
and then on top of that, most of us are located in major metropolitan areas, which, because that's where you would need to get that client base. but there's so many people that don't live near those areas. And
Mm.
so it's a service I've started to really help. I love working with vets, trying to help them even practice a higher standard or just offer more options to their pet owners. Because what I do is I talk with the vet, but I'll actually talk with the pet owner too. So that's where I'm kind of a hybrid from some of the other services, where
Yeah,
I'll do a live video chat with the pet owner, but it's also with the vet. And the vet is very important. One, because sometimes things do change on exam. So I have them do a quick exam, or sometimes, you read through the records and something may sound one way, and then you see the pet and you're like, oh, wait, that's not what I was actually expecting. So I like having the vet. And then also telemedicine laws wise, the vet needs to be there in most states. So it's a nice way because I feel like, especially cancer, people just have so many questions, and it's a lot to put on, like you said, the primary vet, the first line, they're just trying to see everything and trying to help people. And it can be impossible to know everything about everything. And when it comes to cancer, it's usually loaded with tons of emotions, and people already have other thoughts and experiences. And so I feel like that, especially that initial consult, is really to just stepwise go through what's going on, what testing, if we need to do any more, or, what you would do for monitoring, and then treatment and big picture. And I feel like a lot of people, whether they decide to do anything or not, they feel so much more empowered after having that conversation because now they
yes,
know what to expect. And I think having an oncologist do that, one, it takes that burden off the vet because, like I said, you can't know everything. I mean, God forbid somebody come to me with an ear infection. Like, I don't know what to do. Go see your vet, right? Like,
yeah,
I
yeah,
can't. So I understand, especially cancer is not every vet's forte. And
yeah,
the other thing I found after doing this is pet owners are so much more comfortable when they're at their vet's office. I think because they've already been going there, they have a rapport, they know everybody. It's not all this newness versus going to a new specialty clinic. It's all new that, there's just that extra level of stress. And so I do find they love being with their vet. And they also love when their vet can do that for them, where they don't have to drive maybe several hours, or,
yeah,
for some people, it's just going somewhere new. I feel like distance, it very much depends on the person. Some people will be like, oh, that's 20 minutes outside of my bubble, I won't do it, versus other people are like 2 hours, and
yes.
so everyone
Yeah,
has a little bit different perspective on that.
I think it's a really, really nice model because obviously there's been all sorts of telemedicine models come out, post pandemic. One of the things I like to pick up on in this way, with you having the much closer relationship with the first opinion vet, it's a real opportunity for educating and learning for the first opinion vet as well, because it's nice if they're picking up the more common things and then they're not ringing you about those. Your referral vets are then actually sending you the more taxing and interesting cases. You have to thinking about it a bit more, which makes it more satisfying and more of a stretch for you, doesn't it?
Yes, and that is very true. Some of the tumors where, I see on my schedule and I'm like, this doesn't even need an oncologist. Now sometimes that's pet owner driven because they just heard
Yeah,
cancer, so they want to see an oncologist. But
yeah,
I think having the vet know what the different options are, and there's so many more pill options. I don't know about the UK, but in the US, you have to have a lot more special equipment for IVs. We're worried a lot more about handling these days than we were, like back when I started a while back. So I think that's a nice thing for vets because a lot of them don't even know those pill options exist. And a lot of times, pet owners, they would prefer pills if it's a good option, So it's kind of
yeah.
going over what all the options are and what to expect with them.
And it's interesting because America, certainly for CPD, is very regulated compared with the UK. And yet in the UK, we have the cascade system, which stops us using certain medicines. Whereas in America, I believe there's quite a lot of opportunity to be using some of these monoclonals that are coming out as human medicines, but are having some success with animal tumors as well.
Yeah, we've got a bit of free range over here. It seems
Yeah,
like as long as it's been FDA approved for some species, we can use
yeah,
it.
yeah,
But there is a whole debate over that. Like you brought up monoclonals, which is a great topic because, we have all this data on people because, to get it FDA approved, it's a lot of work. But
Yes.
then we're kind of trying to piggyback off that in veterinary. But the problem is we then don't have like the pharmacology data, so we don't really
Yeah.
know like what is the optimal dose? Are they absorbing it? So there's this whole pretty fiery debate if you actually hear some of the topics.
Yeah. Brilliant. And who knows? We may get a mention of that at AVMA in Texas in June, which I'm hoping to get to. And I know you're speaking at it. What are you going to be speaking about at AVMA this year?
So I'm going to talk about one of my lectures is what oncologists wish the GP knew and did. So really walking through like, because I think there's always sometimes that disconnect when you're the first line vet of like, well, what do they really want? Do I just punt immediately? Do I just send them the case immediately, or should I do some stuff, or are they going to repeat it all? So anyway, really going through what the oncologist would like, right, and
Yeah.
just kind of what vets can do. So that's one of my talks, and then the other one I'm going over different advances, so different tests and therapies that are out there, but also kind of highlighting some of the issue that there's not a lot of oncologists. And so to try to, even oncologists to keep up with all this stuff, I go in a little bit about teleconsulting because they've actually started doing that some more in pediatrics. So pediatrics, in people with kids, it's very similar to veterinary, right? Your patient can't always talk or really
Yeah.
explain what's going on. And there's been some studies out of California which found that if a specialist got on, especially a video chat with like these rural hospitals where, again, access is a problem, they really
Yes.
found that it helped lower medical errors and also increase everybody's, I can't think of the word now, but essentially happiness, right? The doctor word for happiness, because they were able to help work with the primary physician there in the rural areas and the family. And so they were able to figure out, like, dermatology was a big one they did a study on where they really found that if the dermatologist could get in remotely, the diagnosis actually changed. Like, I want to say it was like 60% of the time, So it's really helped in those areas where maybe those people can't, go several hours to a specialty hospital.
And one of the reasons I set up Webinar Vet, 14 years ago when nobody knew what a webinar was very much by virtualizing it, you're saving people's time. I used to, at the end of an evening surgery, jump in the car, travel to Manchester or Preston to do an hour of CPD, CE, as you would call in America, have a drink maybe in the bar with some colleagues, and then get home at midnight. And that 1 hour of CPD had cost me 5 hours. Similarly, when I did dermatology, yeah, I probably knew a bit more than the average GP, but the biggest blessing I had was to have an hour with the clients because you can learn so much more in an hour. And of course, if we're struggling with time, if we can save that client from having to spend 3 hours, 2 hours in the car, going to Arizona and then going home from Arizona, 6 hours is a massive amount of time, isn't it? Which allows them to do other things. And as we said before, if at the same time the doctor in the community hospital or the vet in the rural town is learning as well, that's a beautiful sort of combination, isn't it?
That is, yes.
Well, it's really fascinating, I think, what you're doing with the service because it's quite unusual in the sense of with a lot of telemedicine, it's either the client is speaking to somebody who's never been their vet before and doesn't really know the animal, or it's a vet to their client but at different hours to make it easier. And then often with the telemedicine, it's vet to referring vet, whereas this is bringing all three people in plus the dog or cat at the side. And I think it really helps. It's a much more holistic approach than maybe some of the other strategies that we're thinking about.
Yes, I totally agree, and I think it's nice because there's times, like I said, the vet will say something or show me something that, like, when I was reading the record, like, if I had just saw this pet at, my specialty hospital, I would have missed that, like, I didn't quite catch that in
Yeah,
the records or the history, so it is so nice to have us all talking together, and again, I find the pet owner, they also feel more comfortable because they're already comfortable with their vet, and then
yeah,
when you bring in somebody new, if their vet is agreeing, then that makes them feel more comfortable too.
exactly. Before we finish, obviously it's been great to hear about that. You did your masters in new treatments of oncology. We've talked a little bit about the monoclonals, but what is the one treatment that gets you the most excited for the future?
I'm excited for the immunotherapy. They've been looking into this, honestly, a century. The vaccine, from the tumor itself really came out over 100 years ago. And what we found is it only works in a very small population of people, because it's kind of, well, if your immune system didn't recognize the tumor is foreign the first time, injecting it again, they don't always recognize it, so that's why that doesn't work. And then in the 70s, there was a lot of work with immunotherapy, but then they had bad side effects, so it kind of went away to the wayside. But now checkpoint inhibitors, that's something in people that has taken off in the last decade or so, like Keytruda is one that I've seen a lot of commercials for. And in dogs, we just came out with one. It's by Merck called Gilvetmab, and they studied it with mast cell tumors and melanoma. So that's kind of where it is at the moment. But I think that could be really interesting because we're not seeing as much side effects. You don't have to have all the special equipment to give it. It's just trying to use another part of the body. Because I think treatment for oncology, especially if it's a more advanced cancer or really aggressive, you're going to need multiple therapies.
Yeah,
Unfortunately, it's not just one and done with something aggressive. So I think having other approaches to go after the cancer, I really think immunotherapy is going to be that next tier that hopefully will really help to move the needle, because we have so many cancers that we really haven't done much with in the last few decades. So it would be nice if we could find something to really help move that survival time needle.
and as you were saying, a lot of tablets coming in. Is Gilvetmab a tablet form of chemotherapy?
No, it is an infusion. So it is something you have to go to the vet's office. I want to say you give it over like half an hour or so.
Yeah,
So it is an infusion. Unfortunately, it's not pills. But I do think it'll be interesting to see how that works. And, we're still looking for other monoclonal antibodies and things in dogs. And so we'll see where the future, they're getting that in people. So hopefully the future in dogs will find, and cats. Nobody ever looks in cats, but hopefully at some point we'll get some cat products.
yeah, brilliant. And is Gilvetmab now licensed in America, or are you still waiting for that?
It's conditionally approved. So it's
Yes.
that middle of the road where essentially I think it's USDA. So we have USDA and FDA are the two big regulatory bodies when it comes to drugs. And so they're basically saying, okay, it looks safe enough. You can start trying to sell the product to now get more data. So, it's something where you definitely have to tell clients, like, hey, we're still learning about this, but this is what we've seen so far. This is what's been reported. And then hopefully, I'm not sure what the timeline is. I would guess usually it's like 3 to 5 years, something like that, that they would get the full approval. Like I said, I'm not sure where it is for this drug, but somewhere in there.
This is the exciting thing about going to conferences like AVMA, because I can remember as a dermatologist hearing about Apoquel and Cytopoint, which is obviously a monoclonal, and we knew it was coming, and then it came and things, and so it's something to look forward to in the treatment of oncology. So I will look out for Merck's Gilvetmab, and remember, you heard it here first on VetChat. Rachel, it's been absolutely fantastic speaking to you. Hoping that maybe we might do a face to face if I get over to Austin in June time. But thank you so much for spending time. I know how busy you are. Really appreciate it, and love the model of the cancer care consulting. As you say, it does exactly what it says on the tin, which is always good. And just wish you continued success with it.
Oh, thank you so much. It's definitely been my pleasure to be on your show.
Fantastic. Thank you so much, Rachel. Thank you, everyone, for listening. This has been Anthony Chadwick from the Webinar Vet, and this is Vet Chat, the number one veterinary podcast in the UK, coming into America as well. So it's great to have you on, and hopefully see you on a podcast or a webinar very soon. Take care. Bye bye.